This conference will now be recorded.
Okay, so today we are going to discuss this talk, 2017 October talk, that is contraceptive methods and issues around menopause. Okay, so this talk actually it's a very big talk and they have discussed all methods, so basics of all methods also they have explained in detail. So what I have done, I'm not going into details of all these method details because anyways you are going to read it in the FSRH guidelines regarding each individual method, what is its mechanism of action and what is going to do. What is the effect of these contraceptive methods around the menopause? That is only I have kept in this talk so that it will be easy and it will not be a burden, okay? Because it's not, there is no point that you can read it 10 times, okay? Same mechanism of action and same for how many years it should be used. So it is not. Where it matters around the menopause, that only I have taken into this discussion today. So yes, menopause definition, you all know, it is the retrospective definition or retrospective diagnosis. It is a permanent cessation of menstruation caused by loss of ovarian follicular activity. And it is a retrospective diagnosis which is clinically confirmed after 12 months of amenorrhea. The diagnosis is difficult when woman uses method of contraception that interrupt natural menstrual cycle. So most of the time, these with hormonal contraception, diagnosis becomes difficult. No accurate biological marker exists that truly defines the moment when the fertility ceases. Okay, the period of time immediately before menopause, it is called as perimenopause. So according to definition, perimenopause, it includes the first year after the last menstrual period. Okay, first year after the last natural menstrual period. So it is just 1 year before when we call it as actual menopause. And it is when endocrinological, biological, and clinical features approaching menopause they commence. Now, women's fecundity, it declines when they reach their mid-30s. Okay, and also associated with increase of rate of pregnancy loss or abortion. But decrease in the ability to conceive, it does not occur until the women are in their mid-40s. So till mid-40s, women can conceive very naturally. So it is for that you have to use contraception. The woman should use contraception till their menopause. Okay, because nobody can predict the ovarian activity and she can become pregnant anytime. So 1 in 5 pregnancies conceived when the mother is aged 40 years or above, they are unplanned. So 1 in 5 pregnancy above 40 years of age, those are unplanned, and 28% of those end in termination. So now when you are going to stop the contraception, okay, this is the basic thing of this talk. When contraception should be stopped in perimenopausal or menopausal women. So whatever is the method, woman can stop the contraception at the age of 55 without doing any additional test. Woman can stop contraception at the age of 55. Okay, so at the age of 55, no test is required to confirm the menopause and they can stop their contraception. Now for non-hormonal methods, they have divided into two, above 50 years and below 50 years. So above 50 years, when the patient is using or the woman is using non-hormonal methods like IUDs, copper IUDs or any barrier methods. So any non-hormonal method, she can stop the contraception after 1 year of amenorrhea. After 50 years, after 1 year of amenorrhea, she can stop non-hormonal contraception. Before 50 years, she has to continue for at least 2 years after the period of amenorrhea. Okay. So before 50 years, she has to continue for 2 years after the amenorrhea. And after 50 years, she has to continue at least for 1 year after the amenorrhea. Okay. So this is for non-hormonal methods. Now, when you consider hormonal methods, so when the patient is using progesterone only pills, implants, and intrauterine system, progesterone intrauterine system, that is Mirena. So contraception should be continued for 1 year after recording 2 FSH levels more than 30, taken at 6 weeks, at least 6 weeks apart. So what do you mean by this statement? So whenever the patient is using progesterone pills, implants, or intrauterine system, that is LNT IUS, she can do FSH at any time. So there is no need to stop POPs. There is no need to remove the implant. There is no need to remove the LNG-IUS. The FSH can be done at the 6 weeks interval. Okay, and when these two FSH are more than 30, then she can stop it after 1 year. Okay, am I clear? Now, if she is using combined hormone contraception, that is estrogen plus progesterone, so it should be stopped for at least 2 weeks before testing. So whether to stop or not, she has to first stop this hormonal pills at least for 2 weeks. Then she has to do the FSH 6 weeks apart. And if it is more than 30, then she has to continue for at least 1 year and then stop it. Okay. So this is for combined hormonal contraception. The stoppage of hormonal contraception is not required for progesterone pills, implants, and LNG-IUS. But here is the DIMPA, that is injectable contraception. She has to stop at least 1 year before. She has to stop at least 1 year before doing the FSH levels. Yeah, POP and FSH. So what they are telling, the progesterone only pill is also associated with this thing, but FSH activity doesn't this thing. It doesn't matter with this POP, progesterone pills, implants, and intrauterine system. So there is no need to stop this this contraception for doing FSH level. But DMPA for injectable contraception, you have to stop at least for 1 year before doing FSH levels. So you have to stop for 1 year the injections, then do FSH, and after FSH is more than 30, you have to continue the contraception for 1 year and then stop. So please, this slide is very important. Am I clear?
Hello, ma'am.
Yeah. Yes, Shaista.
Yeah. Here, age is not a bar.
Here, age is not a bar. Here, age is not a bar. Okay.
Oh, okay.
But yes, here definitely you are going to think of at least till 50 years you are going to continue it, correct? So before 50 years, you are not going to stop for any patient, because here amenorrhea, you cannot take it as a menopause for any of this contraception. Got it? For any contraception, or either POP or implants or intrauterine system, they are known to cause amenorrheas. So here amenorrhea is not a criteria for menopause. Am I clear?
Yes.
So
Ma'am, actually that means that after 50 years we can test for these hormonal methods.
Hormones. Yeah, not before that. Yes, not before that, because natural age of menopause is 51 years. So after 50 years only,
Yes,
you have to do this test. Not before that. Okay? Not before that you
After
are going to
50 years,
stop.
after 50 years, if the patient is amenorrheic, then we will do these tests to confirm menopause and how long we have to confirm continue contraception.
Yes.
That is the idea.
Then you are going to continue for 1 year. Once you are confirmed the menopause, you will continue for 1 year and then you will stop it. You got the idea exactly? Yeah.
Yes.
Ma'am, but if the patient is on OC pills, the patient will still have some amount of bleeding after 50 years.
Yes. Yeah, that's why. So after 50 years, to confirm whether to continue or not, so for that, after 50 years only you have to do it. So she can bleed after 50 years, correct? So after 50 years, you have to decide when to stop. So for that, you are going to do it. Okay? Yeah.
Yes, ma'am.
Or else you can continue till 55 years and stop at 55 years without doing any test, any additional test. Okay? If the patient is fit to continue the OC pills or anything for 55 years, you can continue it and stop at 55 years. Am I clear?
Ma'am. Yes, ma'am.
Excuse me, ma'am, but
Yes.
after 50 years, when we are like specifically in the patient who is using DMPA, so we said that after 1 year, like we have to stop this drug and then we'll do the FSH level. Then if in that period she gets pregnant, do we need to use any barrier contraception in that particular?
In that period, definitely you have to use other contraception. You have to stop the injection, you have to place on other methods, and then you have to do the FSH. You cannot stop that contraception in that meanwhile 1 year period. Okay?
Okay, ma'am.
Am I clear?
Thank you. Yes, ma'am.
So again, what are the recommendations after this? So it is in, Yeah.
Ma'am, the previous
Yes.
slide, can you go to the previous slide, ma'am? Ma'am,
This
the
one.
second point, the second point, CHC. So it is basically stopped for 2 weeks before to test. So we do the test. Then again,
Yes.
if it shows 2 FSH levels more than 30, do we have to restart it for the next 1 year, or what we stopped is just stopped?
No, no, no. You have to continue contraception for 1 year after confirming the FSH levels. Okay.
For
You
CHC
have
also.
to.
Okay.
Yes, yes. Okay. You have to continue for 1 year after that, and then you can stop. It's not that CHC only. You can continue any contraception after that, but you have to continue
Okay,
contraception
ma'am.
for 1 year after confirming the FSH.
Okay, ma'am.
Yeah. So still, despite all these guidelines also, it is impossible to completely guarantee infertility after stopping contraception. So careful counseling is essential to balance the consequences of unplanned pregnancy with potential health risk for continuing contraception. Okay. So then you have to again tell her that it is not foolproof, but yes, most of the people will not get any pregnancy after confirming this FSH levels. Okay. That is the only thing that you have to counsel, but it is not foolproof. Okay. Now, when the patient requires HRT at the perimenopausal period, so what is the relationship with this HRT and contraception? So if the patient requires HRT for her perimenopausal symptoms, and if you are prescribing her sequential HRT, that means estrogen plus progesterone sequential HRT, it does not act as contraception because it inhibits ovulation in only 40% of women. Okay, so sequential HRT does not act as contraception. So contraception must be used alongside this HRT to avoid unplanned conception. Progesterone only methods and intrauterine contraception are suitable for such patients. Okay. So whenever you are using, and now the another point here is whenever you are using progesterone only methods like implants, injections, or progesterone pills, and the patient requires HRT. So in that case, because she is using progesterone, you should not give only estrogen HRT. Okay, you should give combined HRT in that patient. It should be combined estrogen plus progesterone because the progesterone in this progesterone only pills or implants or injections, it does not provide endometrial protection. Only if the patient is on LNG-IUS for contraception, then only LNG-IUS provides endometrial protection. So in that case, you can give only estrogen, only HRT. Am I clear for this point? This is also very important. So when
Yes,
the
yes.
patient, so when the patient is on either implant or POP or injection, you have to give HRT, that is estrogen plus progesterone. You should not give only estrogen because she is receiving progesterone. Okay, but yes, if she is receiving LNG-IUS, then she is having this Mirena, can give only estrogen HRT because this Mirena provides endometrial protection. So this Mirena is licensed for endometrial protection for 4 years. Okay, so license indication for 4 years, but evidence says it supports 5 years also. But as license condition, it is only for 4 years. Remember. Now, when the woman use this combined contraception, combined hormonal contraception, that is estrogen plus progesterone, they can use shorter pill-free intervals to reduce the risk of menopausal symptoms. So if she having just minor menopausal symptoms, she can just reduce her pill-free interval so that she does not need any more HRT. Now, how you are going to see which method of contraception is good for this perimenopausal woman? So no method of contraception is contraindicated basis of age alone. Okay, up to the age of 50 years. So up to the age of 50 years, nothing is contraindicated. Now you have to take a proper personal sexual family history. Pregnancy should be excluded. BMI, blood pressure should be checked. STI screening should be offered if you want to place a IUC. Okay, it's not compulsory, but STI screening is offered. Okay, pelvic examination is only required prior to fitting intrauterine device. Cervical cytology, it should be according to the NHS guideline. So this is the table in this talk which have given the overall advantages and disadvantages of each method. So here combined hormonal contraception, You can see advantages is bleeding pattern will be regular and reduction in this perimenopausal symptoms like hot flushes and perimenstrual bleeding. Okay. Increased risk of thrombosis, breast cancers, cervical cancers, and daily dosing is required. So these are the disadvantages. Now for POP pills, that is progesterone only pills, contraindications are very few, but the disadvantages like irregular bleeding and it requires again daily dose, so compliance is required. Now injectable contraception, it is a long acting method. Also it induces amenorrhea, but here basic disadvantages of this progesterone only injectables are it masks menopause, bone mineral density loss will be there, and unable to remove after injection. So it is irreversible. So at least for 3 months or 14 weeks, it is irreversible method. Implant, again, very few contraindication. It is easily reversible, so you can remove it whenever you want. Adverse effects are or disadvantages are irregular bleeding, and it requires a trained person to fit it. Failure rate, you all know. I don't have to tell you again that the least failure rates are with the implant. Copper IUD, it is hormone free. It does not mask menopause. It is a long acting method. So these are all advantages. But disadvantages are HMB and unsuitable in case of a distorted uterine cavity or congenital malformations. LNG IUS, it is long acting treatment for HMB, endometrial protection, and so it is the most suitable, but disadvantages are irregular bleeding. And again, if any congenital malformation or distorted cavity is there, you cannot use it. So this is regarding overall advantages and disadvantages. So now in the talk, what they have done, they have discussed each and every contraception in somewhat detail, but I have avoided to do that because it is just the same replica of this FSRH guidelines. So I have just taken the important point regarding the menopause. So remember well, combined hormonal contraception beyond 50 years is not recommended. Okay. So beyond 50 years, you should not prescribe combined hormonal contraception. Again, this combined hormonal contraception should not be used in the women who are smoking and who are over the age of 35 years. So see, if the woman is more than 35 years plus smoking, less than 15 cigarettes per day, it is a category 3. Okay, you can make category 3, and more than 15 cigarettes per day, more than 35 years is a you can make category 4. Okay, so it is almost contraindicated in smoking plus 35 years age. Progesterone pills, they do not cause any blood pressure elevation, don't have effect on lipid profile, and also diabetes effect is very minimal. There is VT risk is not increased. Okay. Also, they are safe for women suffering from migraine with aura. So migraine with aura is again UKMH4 for combined hormone contraception. Okay. So this POPs, they can be used in all these conditions. POPs can also be used in case of smokers over 35 years of age. Then when you consider implant has no effect on bone mineral density. There is no evidence that it failure rate increases up to 149 kg. Okay, because some injectables and POPs, sometimes the BMI affects this efficacy, but implant does not have any decreased efficacy up to 149 kgs. Okay, and no limit. So you can replace it every 3 years till any year of age. So no age is bar for the implant. Now, when you consider injectable methods, the major issue is bone health. So 5% of bone loss is there within first 2 years. 5% of bone loss is within first 2 years of use. Again, it is a commonly asked SBA. So, but the thing is, bone loss after 2 years of this injection, it is equivalent to bone loss during pregnancy and breastfeeding for 6 months. Now, FSRH recommends that you you have to consider stopping this injectable at around 50 years. But again, it says that if you continue this injectable beyond 50 years also, it is unlikely to result in unacceptable adverse outcomes. So you can prescribe after careful counseling to the woman. You can give it after 3 years of age regarding these injections. Now, intrauterine device. Now, when you see this intrauterine device, it is copper. Okay. In this, the TOG are everywhere. FSRH, IUD is for copper, and IUS is for progesterone IUS. So IUD, it is an effective and safe form of long-term contraception over 40 years of age. And when inserted in women more than 40 years, it can be used until menopause. Okay, and this IUD must be removed after the menopause or when no longer required. So after 40 years, if you have inserted this copper IUD, no need to remove at 5 years or 10 years. You can continue up till the menopause. These IUDs have minimal systemic side effects, so it can be safely used in women with comorbidities like diabetes, hypertension, cardiovascular, CVA, or thrombotic diseases. Levonorgestrel IUS, it is a reliable, cost-effective contraceptive which releases very low systemic levels of progesterone. Okay, so 4% of perimenopausal women in UK, they use levonorgestrel IUS. Now, for women with perimenopausal age, the most important benefit of this 52 milligram LNG IUS is effect on this menstrual bleeding. So, within 3 months of insertion, the blood loss is reduced by more than 80% in women who are having this HMB. And there is no evidence to support a link between breast cancer and IUS use. IUS has minimal systemic side effects, no risk of VTE or other systemic disease, no evidence of weight gain. So it is a safe option for many perimenopausal women, especially those with HMB. So these are all things, these 2 or 3 slides, basically, these are for EMQs regarding the contraception around the menopause. Okay. Now, when to use barrier contraception? So barrier condoms, they are used by 10% contraceptive in perimenopausal. Diaphragm and spermicides, they are loose 1%. But barrier contraception is safe to use until menopause is confirmed. So whenever you are doing this FSH levels and you want to stop the contraception, hormonal contraception, barrier methods are best to prescribe. Okay. Now, whenever you are prescribing oil-based lubricants or estrogen-containing creams for this perimenopausal vaginal atrophy or these things, so it should not be used with condoms or latex diaphragm because they can result in its breakage. But this oil-based lubricants or estrogen creams, they do not affect silicone diaphragm or female condoms. But male condoms, yes, they affect it, so better not to use it. But use with condoms, okay, and it also improves the sexual difficulties because of vaginal dryness. No latex. So latex allergy you have to take into consideration, and diaphragms and condoms should not be used in case of latex allergies. Natural methods, that is fertility awareness methods, they are used by only 4% of older women. These are less reliable in perimenopause because ovulation becomes more difficult to predict. So they are difficult to use. Again, another method is withdrawal. It is a natural form of contraception. It is used by 5% of UK perimenopausal couples. Now, the interesting fact they have given here in this talk is it prevents approximately 50% of pregnancies that would have happened without using this method. Okay, so this is the statistics they have given. With the lower fertility rates in perimenopause, withdrawal can be used as an adjunct to natural fertility awareness methods. Sterilization. So female sterilization is permanent and highly successful form contraception, and it is used by 18%. So female sterilization is used by 18% of UK women over 40 years. But whenever a woman wants to consider sterilization, she should be counseled regarding all the long-acting methods because these are as reliable as sterilization. The woman who is approaching menopause and she will naturally shortly reach this natural menopause, they should consider LAR rather than surgical method because of this complications associated with the surgical method. Again, important thing, these 2 points, vasectomy failure rate 1 in 2000. Okay, remember well. So vasectomy failure rate is 1 in 2000. Female sterilization failure rate 1 in 200. These 2 numbers you have to remember. Okay, there is no alternative for that. Chronic post-vasectomy pain occurs in around 14% of men. But regarding female sterilization, other than preventing pregnancy benefits, Okay, but it is associated with surgical risk. And regarding emergency contraception, everything is safe. All methods of emergency contraception are safe in perimenopausal use. So they should not be contraindicated, or they should not be difficult to prescribe. So anything can be prescribed as an emergency contraception method. Nothing is contraindicated. Okay. So this is regarding this. Sorry. This is regarding this talk. Now, actually, the strategy questions of this talks are not related to this talk only. There were two questions. I have not taken those two questions. One is disogestrone mini pill. This thing. What do you mean by this pill for disogestrol pill? So you know it is how many hours? Disogestrol pill, mist pill is 36 hours.
12 hours late, ma'am. 12
So it is
Well,
36 hours. It is 36 hours, correct? Yeah. And for routine POP, it is 27 hours.
2 hours.
Okay, it is
2 hours.
3 years.
20.
3 years.
Yes,
Three.
3 years.
It is 27 hours. Huh? So that was the one question. And another thing is the DVT risk is increased in which generation of progesterone? So it is in third generation of progesterone,
generation.
correct? In combined
Third
hormonal contraception, third generation of progesterone, this DVT risk is increased. So these are the two topics. I have taken those, but I have taken two different questions for this talk. So this is the first question. Sorry. A 51-year-old female, she's using DMK injections for contraception. She's getting menopausal symptoms and wishes to stop her contraception. When can she stop the contraception? Please read
The
it
answer should
carefully,
be
all of us.
D.
Please type in your chart. Yes, here answer is D. As I told you, you have to wait for 1 year. After the last injection, do FSH 6 weeks apart. If more than 30 years, 1 more year and then stop it. Okay. So answer is D here. Next question. Combined hormonal contraception can be used for which of this patient you can use combined hormonal contraception? Please type in your chat box. Yes, very good. Answer is C, because myelin vera is contraindicated. 15 years, 15 cigarettes more than 30 contraindicated. More than 50 years, it is contraindicated. History of DVT is contraindicated. But family history of breast cancer is not a contraindication. Okay, it is CAT1 UK. So answer is C here. So thank you for attending today's talk. Tomorrow is Friday, so no discussion tomorrow. We will have on Saturday. Yes, there is a group, Aditi. You are not a part of this group. It is MRCOG Part 2 Intense Preparation. Okay, it is a group. You can just become a member of that group. Daily I am posting notifications for these classes. Okay, so bye for now.
Ma'am, tomorrow is a class starting at 5?
Tomorrow, yes. Tomorrow the paid class. Tomorrow paid class will be there.
Yes. Okay.
Talk class will not be there tomorrow.
Yes.
Day after tomorrow we will meet for this talk class. Okay.
Okay.
Ma'am, I have a small doubt.
Yes, Ankita.
Ma'am, should STI screening should be done before prescribing COCs?
No, not necessary. Not needed.
Because ma'am, there is a question in several books that what should be done before prescribing COCs, and the answer was BMI, blood pressure, and this STI screening. That's why I'm asking, ma'am.
STI screening is
It's
only for
in just in technology.
No, not required.
Yes.
STI screening is not required, but STI screening is offered for every sexually active woman, but it is not compulsory. Okay. So it is not a compulsion, but yes, you have to check BMI, you have to check the BP, you have to take complete history and family history.
Okay, ma'am. Thank you.